right, just one moment, Donna.
Okay.
All right, you're good.
All right. Good evening, everyone. Today is Wednesday, April 28th, and this is the United Medical ACO Diabetes Program Wednesday Wellness Webinar. We want to thank you for joining us this evening. And my name is Donna Gunkel. So I am part of the Wellness Program team here at United Medical, the Director of Clinical Integration. Kamal Erkin is our chairman and the United Medical ACO. We have Dr. Hundal, one of the endocrinologists in our network, and he is our program director. We also have Tim McHugh, who is a physical therapist and meets with us several times a year to talk about fitness and education on exercise. We have Amy Wilcoxon, who is our registered dietitian and certified diabetes educator, and she's here with us this evening. She runs our program for us. We also have Jacqueline Tomasetti, our licensed clinical social worker, and she also meets with us several times a year to talk about various aspects. In fact, she was here with us earlier this month talking with one of our dietitians about goal setting. She also talks to us about stress and other things that may affect our health as well. So I'm going to go ahead and turn it over to Amy to talk a little bit about what our program entails.
Thank you, Donna. So welcome, as Donna said, to our Wellness Wednesday webinar program, where we meet twice a month on Wednesdays to talk about diabetes and everything to do with diabetes. So we've had Dr. Hundal speaking several times, talking about medications, diabetes itself, cardiology, talking about how diabetes affects heart and kidneys and the feet and the eyes. Excuse me. Goal setting, as Donna said. So talking about how mental health and how that's affected by diabetes. So we're trying to get into all the different parts, since we can't teach our classes anymore, to help people manage their diabetes. So and if we could advance the next slide, please, Donna, thank you. I am very happy to have Dr. Vade with us tonight. Thank you, Dr. Vade. He's going to talk about diabetes and GI and the gut. So it's something that we always have a lot of questions about with our patients when we see. So we appreciate you taking the time to speak with us. And I will turn it over to you.
Absolutely. Thanks, Amy. Good evening, everyone. We will be talking about the diabetes, which is a systemic disease, and how it involves the GI tract. Diabetes involves a lot of places in the GI tract, but we'll talk about the four main ones. One is the esophagus, which is the food pipe. Second is stomach, and it causes gastroparesis, which means slowing down of the way the stomach moves. Next is the small intestines, and in which it causes this thing called enteropathy. And the last one will be about diabetes and how it affects the liver. So the diabetes and esophagus. What diabetes does is, because of deranged blood sugar control, it causes abnormal contractions. There can be some spontaneous contractions and impaired lower esophageal tone, leading to heartburn and dysphagia. In our body, whenever we eat, food needs to move like a worm, like our food pipe and our stomach. It needs to be in a coordinated fashion, meaning if there is a contraction in one end, the other end needs to relax. But if there is an abnormal contraction or two ends are contracting simultaneously without relaxation, that's when we get these pains, the dysphagia, meaning difficulty eating, and heartburn, meaning like there is food in the stomach and it tends to go up rather than going south where it needs to go. And that's because of the deranged nerves, which diabetes causes. Diabetes, especially type 2 diabetes, is also associated with obesity. And as you know, obesity can, just by virtue of increased pressure, can cause reflux. Because there is increased pressure in the belly, stuff tends to go up north rather than down south. And what kind of treatments we offer these patients? I mean, first and foremost is to improve their blood sugar intake. They can take some over-the-counter anti-reflux medications like Prilosec, and of course, weight loss is a big one because you want to reduce the pressure in your belly, and once you reduce that, then things are, I mean, the tendency would not be for it to go up north. Gastroparesis, it means lazy stomach or impaired gastric emptying, or basically discoordinated gastric motility. Normally what should happen is when food hits stomach, our lower esophageal sphincter should contract, they should close, there should be contractions on the side here, and the pylorus, which is the opening of the stomach into the duodenum, which is the first part of intestine, that should relax. That would be a coordinated way in which food comes into the stomach and goes over there. There is a nerve called vagus nerve, and that gets involved and deranged when you have diabetes, especially when you have totally deranged blood sugars. That's when the discoordinated movement starts. So basically, the pylorus is not relaxing, lower esophageal sphincter has relaxed already, it should contract. So instead of food going south, it tends to go up north, again, because of deranged nerves, because of impaired blood sugar control with diabetes. So that's called gastroparesis. What are the common symptoms? Of course, people are going to have nausea, vomiting, they're going to feel full, bloating, they'll have upper abdominal pain because they are not able to just empty their stomach. I mean, and the commonest cause is, of course, the impaired vagus nerve. And typically when people come to us, hey, I'm having this nausea, vomiting, and upper abdominal pain and bloating, we typically start off with performing an EGD, which is a scope of the upper GI tract. We can also do some contrast studies, meaning we ask them to drink some barium or some gastrographin, and we can take x-rays just to see how the motility of the stomach and the whole system is going. The third test is a gastric emptying study. It's basically a radionuclide study. What we do is we tag food with some radionuclide substances, and we measure the amount of gastric emptying in time, like 20% has emptied in, say, 5 minutes or not, and things like that. How do we treat it? Sugar needs to be better controlled. Dietary and lifestyle modification is important, of course. If something's hurting you, you need to avoid that. We can try prokinetic medications like Reglan and erythromycin, but of course they have their own side effects, so I would not just quickly jump onto that as the first line. And then there's a stimulator called a gastric stimulator. It's a nerve stimulator which can be deployed in the stomach, and it can actually stimulate the vagus nerve and help in the gastric emptying. Then in the small intestine, diabetes can cause intestinal enteropathy. It is also a neuronal dysfunction due to uncontrolled diabetes. Symptoms can include diarrhea, meaning going too much, constipation, meaning the colon is just not able to empty, and fecal incontinence means that because they're going too much, they're actually losing control of their bowels. Also of note to know that metformin, which is a very, very commonly used drug for diabetes, that can also cause diarrhea. So we need to be able to we should be able to distinguish whether this is happening because of uncontrolled diabetes, or is it a new medication we started and that's why we are having the side effects. If we are having those, then of course we can have a chat with our PCP and we can figure that out. Treatment for intestinal enteropathy, high fiber intake, physical activity, better glycemic control, and we can try some Imodium, which is like an antidiarrheal medication. Diabetes also affects liver. The first stage of liver damage is called fatty liver. This is a non-alcoholic fatty liver disease, as opposed to typically when alcohol leads to liver derangement, we call it an alcoholic liver disease. So this is a non-alcoholic. It is not related to intake of alcohol, but it's caused by Western diet, meaning a diet high in red meat, low in fiber, high in fats, type 2 diabetes, people having insulin resistance, and a sedentary lifestyle leads to accumulation of fat in the liver. That with time progresses to cause scarring in the area where there is deposition of fat. This is called NASH, non-alcoholic steatohepatitis. Up till this point, things are kind of reversible. Once we get beyond this into the cirrhosis area, now there is a permanent replacement of scar tissue where there was inflammation. And if it kind of keeps on going further, and it can actually progress to hepatocellular carcinoma, which is cancer of the liver. How do we treat it? Simple. Everything is very straightforward. You got to have a better glycemic control, weight loss, physical activity. It's not rocket science. Before I go on to the gut microbiome, do we need to talk about anything else about these 4 conditions we touched on?
The one question that I have, so you talked a little bit there about the liver and, you know, where it's reversible and where it's not. So what about some of the like gastric reflux? So if they do the same types of things, right, if they get their weight under control and they get their blood sugar under control, those two are reversible types of things, correct?
Absolutely, absolutely. Gastric reflux is a very, very common symptom which people have. And it's not like people have it on a daily basis. Some people have it only on days when they say, eat a lot of spices, or if they've eaten a lot of heavy food, like calorie-rich food, fatty food, or if they're not giving enough time between their meals and going to bed. So typically when people have gastroesophageal reflux, we say, you know, lifestyle changes, which means you should avoid spicy food, avoid smoking, and try to have at least 3 to 4 hours between your dinner and you going to bed. And of course, I mean, if you lose weight, there's going to be less pressure in the belly, which is going to prevent you from having reflux and things like that. Yes, to a point, they are reversible.
And I have a question also. A lot of my patients have irritable bowel. And so we talk about, there's a lot of the foods that they're eating that are triggering their irritable bowel. So we'll keep a symptom diary and things that I'm sure you're used to seeing, like dairy and too many fatty foods and fried foods and things like that. But one of the questions they will often ask is, if I have high blood sugar, which may be triggered by those foods too, but is the high blood sugar itself triggering the IBS?
Absolutely. What is IBS? IBS is a condition when you have these symptoms of either constipation or diarrhea with bloating and abdominal discomfort ongoing for at least 2 to 3 months. And you do your colonoscopy, you do your endoscopy, and we find no organic cause for these problems. And then we say, hey, you know what? We don't know what's causing it because we cannot kind of pinpoint it to say ulcerative colitis or Crohn's disease, but you are having these symptoms. And probably that's why the diagnosis is IBS, Irritable Bowel Syndrome. IBS is triggered by a lot of things, stress being the most important one, actually. Typically, it's seen in females who get stressed out and then they have these panic attacks and then they have these IBS-like symptoms. So that's one. Diabetes is a big one for IBS. I mean, your sugar control out of whack. I mean, you're going to have nerve problems, which are going to cause constipation, diarrhea, which are very similar symptoms to IBS. And diet, of course. One thing, Amy, which is a new thing, I'm sure you probably already are advocating to your patients, is a diet called Fodmap Diet. Mm-hmm. So avoiding that kind of diet, and it's a matter of elimination. We don't know which component of what diet is actually causing you to have these symptoms. So basically, it's an education of these are the diets. Let's kind of start looking at it and seeing if we can eliminate them from your diet. Are your symptoms improving or they're not, basically. That's how I approach the IBS scenarios.
Yeah, well, thank you. We certainly do see a lot, and women, as you said, a lot of people with IBS, especially a lot of women. Thank you. I can't wait to hear what you have to say about the microbiome.
Microbiome, yeah, that's another new one. When Donna had asked me about this, I thought she was more interested in the microbiome rather than the diabetes. So how do I go back to this?
I'm going to share again, just 1 second, Dr. Vade. Sure. Can you see it? Can you see my screen now? Okay, yes. So if you just request control and then we'll be right back on.
Perfect. So gut microbiome, this is something which we've been talking a lot about for the last few years. And basically, this is the population of good bacteria, viruses, and the microorganisms which are living in our gut. These guys are our good friends. They're not bad people. They are our friends. And they do a function in our GI tract. And the function they perform is they break down harmful food molecules, complex carbohydrates, so that our body can use those products for nutrition, muscle function, and prevention of certain chronic diseases. So these are healthy bacteria, so to speak, which need to be inside our body. And there can be a drastic change in the gut microbiome, which can lead to greater chance of inflammation of the intestines. And that can certainly lead to diabetes. In addition to, it can also lead to a lot of other conditions. But since we're talking about diabetes, a change in the gut microbiome can cause inflammation of your intestines and can cause diabetes. On the other hand, certain microbes prevent gut permeability, which is actually seen more in people with diabetes. It's called a leaky gut, because these microbes, these bacteria, they increase the permeability of your intestines. You are more prone to now getting diabetes. So it's like diabetes can cause problems with the gut microbiomes, and also gut microbiome can lead to diabetes as well. Of course, some microbes can influence blood glucose level because of the amount of digestion they are about to, they can perform, and amount of food they can break. And it may also affect the production and release of the gut hormones, which may cause varying degree of insulin sensitivity. So it's not about how much we eat, it's also about what our hormones are feeling about what we are eating. So insulin, and as you know, there needs to be a delicate balance. If our hormones are in a level of homeostasis, meaning that everything is happy, if you eat healthy, you will be good. But some people are like, I eat nothing and I'm gaining weight, while others are, I can eat anything and I'm not able to put on anything on myself. That's all interplay of how your gut hormones react to these things. So how should we improve the gut microbiome, or the system we have inside of us? We got to go back to the natural plant-based diet. All this artificial sweeteners, all the extra refining which we've done over the last 50 years, we thought in the 70s and 80s that we were smarter and we were doing all that. We are having a Diet Coke, which is a Coke Zero, so I cannot get fat when I drink that. On the contrary, calorie is zero, but the hormone derangement is such, I'm actually putting on more weight now if I'm going to have that Diet Coke. And the reason for that is high fructose corn syrup. I'm sure it's been talked about so much, and artificial sweeteners which are there. So high fiber diet, going back to your roots, that's what you want to do. You need to reduce the amount of sugars and the artificial sweeteners. Antibiotics, if they're not necessary, because as you know, antibiotics can alter our gut microbiome, and that's why C. diff in the 2000s, even now C. diff is a major problem. But that's when the doctors realized that what's happening, I'm treating someone for some UTI, and now they're coming with this severe diarrhea, abdominal pain, and they are in sepsis, and some of them are dying. What's happening? We realized that we are actually altering the gut microbiome, allowing C. diff, which is a bad bacteria, to grow, to like overpopulate and cause toxins and problems in our colon. Reducing stress is a big one, exercising, getting a good quality sleep. Now that's very, very variable for people. Some people say 6 hours, some people say 8 hours. I think 8 to 10 is a good amount. 6 to 8, you can function. But once, in my opinion, once you get beyond 8, it's a constant sleep deficit and you got to pay. This is a debt you have to pay at some point. So either you pay it this week or next week. Unless you catch up, you will not be in a happy place. And of course, not smoking and things like that. So I think that's what I have for you guys. I think this is Amy's turn, right, Amy?
That is my turn. Although I have another question about my favorite topic,
Sure.
the gut microbiome. And I know it's might be a little controversial. Well, I don't want to say controversial opinion, I guess. I get a lot of questions about organic dairy and organic meat and organic produce with the gut microbiome. And I know there's been a push for conventional meats to stop using antibiotics for growth in animals because of all of this with the microbiome. Do you have any thoughts?
Absolutely. So I believe in staying as natural and That's why I said, going back to your roots, as long as you are what God intended for you, you're going to be healthy and you're going to be fine. The moment we start kind of making changes with that, that's where the problems arise. So organic meat is basically natural meat. We have altered it into an inorganic meat. That's why today we're talking about organic meat and organic dairy. Meat and dairy is not supposed to be antibiotic fed, hormone fed, and made like a 5-pound chicken into a 20-pound chicken. That's not a chicken anymore. That's a pony, perhaps. So that's what the thing is, organic and inorganic. Typically, healthy is all organic these days because that's the label we have. That's the name we have. But yeah, I totally agree with you on that. Once we get unnatural, that's where all the problems happen. So for today's day and age, that term is organic. So I would say stay organic.
Okay, great. Thank you. Thank you.
Sure.
Like I said, one of my favorite topics. I went to a big conference on the gut microbiome when I was pregnant, which is maybe not the best time to go.
Right.
But very interesting. All right, Donna, can you open back? And then I need to request control, correct?
Yes, please.
All right.
Okay, we're all set.
Be in business. Okay. So starting to talk about reflux with diet in particular. So, and as Dr. Vade said, weight is definitely a factor. So as the stomach gets bigger, there's more pressure and things move up. As the stomach gets smaller with weight loss, things move down as they're supposed to. So one of the big trends right now we see with eating is this intermittent fasting where you eat one big meal and that's all you eat. That's really an enemy for GERD. It's too much food at one time. So we do like small, frequent meals. Laying down. So if you think about if your food is sitting right here in your esophagus and you lay down, things are going to come back up. So avoiding laying down after you eat. Some people do have to sleep propped up, unfortunately. But I really like for digestion anyway, to have 2 to 3 hours between food and bed, and for blood sugar too. So some of the common irritants, and I really like, and Dr. Vade, you can chime in, I really like for people to keep a symptom diary. I don't want you to cut out everything if it doesn't bother you. I mean, there's quality of life here.
Absolutely, I agree. That's why I tell them about this Fodmap diet, this and that, and say, all of that cannot be problematic to you. This is like for population in general. So you figure out what is your trigger, and that perhaps is the one we can eliminate. Yes, a food diary is. Yeah,
we don't want you to cut everything out. So some of the common ones, fat is very slow to digest. So it is going to sit at the top. And if you have too much fat at once, you might feel some of that coming back up with GERD. Foods that are acidic or spicy foods typically can cause a problem. So some examples with fats would be meats or dairy, ice cream, fast food, chocolate. For acidic foods, red wine, tomatoes, vinegar, and citrus. And then spicy foods, peppery foods, chili powder, hot sauce. And then caffeine. I did read something recently that caffeine is considered maybe less of a trigger than it was thought. I guess the standard recommendation for years was no coffee. And I don't know if people complained, but certainly it can be an irritant, right? Caffeine. So again, it's because a lot of people say they're not willing to give up their caffeine. And if it doesn't bother you, then it doesn't bother you. All right, let's see if I can. Ooh, did I just go too far? No, okay, no, I did not. All right, I was missing my arrows. Thank you. All right, so fatty liver, and Dr. Vade talked about fatty liver, that first stage. So interestingly, people come in, oh my goodness, I have a fatty liver. I don't know what to do. I'm so upset, which I like that they're a little upset, I'll be honest, because then maybe there's change that we can make there. So the recommendation is the same as the diabetic diet. And what should people with diabetes eat? The same thing that we're all supposed to eat. So a lot of fiber, as Dr. Vade talked about before, fruits, vegetables. People worry, oh, I can't have fruit, it has sugar. But we all should be eating fruit. 2 to 3 pieces of fruit a day, or 2 to 3 servings of fruit a day. Vegetables every day with lunch and dinner. Legumes, beans are very good for the liver. And then intact grains. So we're very carb phobic in our society, but fiber is carbohydrate. So rather than eating pasta and rather than eating crackers, think about eating quinoa or farro or cracked wheat or millet or bulgur or sorghum or any of those intact grains, because they have the outer layer of the grain, the bran, which is the fiber. And then, as Dr. Vade said, simple or added sugars, we definitely want to limit, which are very prevalent in our diet, refined carbohydrate, and then alcohol. So those are a normal healthy diet really is what we're looking at for liver. And then GERD, for some reason, I'm sorry, it looks like I got out of order in here. So with reflux again, GERD may improve with weight loss, but some people think, well, I feel better. I lost weight, so now I can go back to what I was eating before. But if you gave up fried chicken and French fries and chocolate and wine, and then you put all that back in because your GERD is better, well, then you might gain the weight back. So you might find that as you lose weight, you have a little bit more freedom. And that might be, oh, now I can eat an orange and I'm okay. But it might not be, I can go back to everything I ate before and gain the weight back, because then it's just going to come back. And I do have people that I see who note when their weight is above a certain place, then they need to start taking daily reflux medication. So we work on, well, let's get your weight back to where it was rather than have to take more and more medicine. So gastroparesis, again, small frequent meals, and you want to limit foods that are very long to digest, because as Dr. Vade said, digestion is really slow and it's impaired. So solid fat is very slow to digest, and fiber. Fiber is really healthy. So this is where people get confused. So you just told me to eat fiber. Now you're telling me I can't have a lot of fiber. So again, we're not cutting everything out, but we want to watch really high fiber foods because it's going to take so long, and that's going to cause the pain and bloating. So this is only for people with diagnosed gastroparesis. The stomach chews, that's part of its action, is to really chew food. So in gastroparesis, it can't chew like it's supposed to. So a person has to eat slowly and chew their food very, very well. Because the food is so slow to digest, you can have low blood sugar with gastroparesis if you're taking insulin. So if you normally take your insulin as recommended 5 to 15 minutes before you eat, and your insulin starts working right away, but your food takes an hour to digest, you're going to be in trouble. You're going to have low blood sugar. So work with your endocrinologist. Do I need to take my insulin in the middle of the meal or the end of the meal based on what I'm eating? So let's talk about fiber in particular. Cooked vegetables are much easier to digest than raw. So you can still eat vegetables. This doesn't mean I can only eat crackers and chicken. You can eat fruit and you can eat vegetables, but you might not want to eat a giant bowl of kale and broccoli and black beans. So cooking them smaller portions, considering taking the skin off fruit, that can definitely help. Sometimes people, if they're really struggling with fruit, they will go to the canned in no sugar, drain the juice. And that's easier to digest because it's been processed in the canning process. So it's a little bit easier to go down, and you're still getting the vitamins and the minerals. No, I'm not moving forward so easily. For fat, liquid fat may be a little bit easier. So sometimes in gastroparesis, we're concerned that there's too much weight loss and we don't want any further weight loss. So we don't necessarily really want everyone on a low fat diet. So making sure that the quantity of fat is very small. So having a liquid fat, what does that mean? That might mean something like Ensure, which has fat in it. If we're concerned about weight, a small amount of dairy fat. So something like a low fat milk versus a fat-free or a yogurt. And softer food, remember with the chewing, softer food can also be easier to digest. So a lot of people do well things like chicken salad or tuna salad, Greek yogurt or eggs, because the stomach doesn't have to do as much work and it's not capable of doing all that work. So that definitely can help. So in summary with gastroparesis, the main things to remember is, first of all, you should have a diagnosis. So if you're having the symptoms that Dr. Vade talked about, and your blood sugars are really sort of out of whack, and usually like we'll see those lows and then we'll see it staying high because once the food digests, the insulin's already done. So see these these roller coaster blood sugars with it. So definitely going to see GI. And then going to see your dietitian to talk about what are some specific meal ideas so we can help you. And if there is weight loss, frequent vomiting, definitely make sure we get your calories in. And then also going to see the dentist is something that we don't always talk about what we should, because with all that acid coming back in your mouth, it can be a problem. And I think that's the end for me. That is. So John, I don't need to give you back control. You can take it back yourself.
There. All right.
All right. Any questions, comments?
No, I think Amy, you actually had a very great presentation on like how to manage the food and for certain conditions. Gastroparesis, just one comment I want to make, which you said that eat smaller meals, and for the most part, your symptoms will be very well controlled. It's very rare for gastroparetic person not to be able to manage their symptoms just by these simple measures of better blood sugar and eating smaller meals. Mm. Very rarely, once we go beyond that, we get to the prokinetics, which we talked about. And even rarer is the time when we are offering stimulators and such. So what I'm saying is majority will be taken care of just by dietary alteration, which you said, smaller portions, chewing well, and you're going to be actually good.
And my understanding is Reglan is pretty much not used because of all the side effects.
Absolutely. It has Parkinson's-like side effects. That's why Reglan, we kind of moved on to erythromycin. Reglan is still used routinely, I mean, not routinely, I would say sparingly in very, very highly reserved situations, but it's not like it used to be 10 years ago. 10 years, everyone post-op used to get Reglan, but now we are not doing that.
When all of our kids with delayed gastric emptying, we're all on Reglan, or Propulsid before that, and then that one, and then Reglan, and then nothing. Well, I guess erythromycin, but never seemed to be as good, unfortunately. So Donna, any questions, comments?
I don't think I have any other questions. I asked mine earlier. Are there any other points that either of you would like to make, or any other questions, Amy, from patients that you get? Anything else that you wanted to address with Dr. Bate?
Well, I do. So do you have any opinion, Dr. Bate, on going to see GI as something, because we try to get our patients in with specialists in terms of eye and foot and kidney and all of that.
If someone has diabetes, just to see GI for, no, unless they have symptoms, I would say no. Of course, I mean, I'm a colorectal surgeon. For me, colonoscopy is very big. And now, as you know, the screening age is 45 rather than 50. The Cancer Society dropped it to 45. So yes, if anyone is having any GI symptoms, absolutely they need to be looked into. But just, it's not a maintenance thing. For eye, yes, because if you have diabetes for a long time, your symptoms lag behind what the findings might be. So they need a fundoscopy. They need to be examined because the symptoms may be later. Same as with the kidney, but not for the GI.
Okay, oh, good. Okay, thank you. And I do, and to your point about the FODMAP, we do have on our website where we have our handouts, we do have a handout on the low FODMAP diet, which should not be done strictly on your own because it's not a forever thing, as Dr. Bates said. So typically it's 6 weeks, and then we work in a food at a time. And I usually like you to work in what you miss the most and see what you really want to have. I will say I use FODMAP probably as the last ditch because it's so hard. So I will usually ask you to pull out some common offenders. So if somebody's having more diarrhea, it might be dairy. It could be greasy foods, fatty foods. If it's constipation, if someone's eating a lot of insoluble fiber, gas-producing vegetables, not drinking enough water, trying to do those little things before we do the FODMAP diet, which is difficult.
No, it is absolutely, absolutely. So the easiest thing which I tell everyone is, or not the easiest, but the recommendation, you got to do about 30 to 40 grams of fiber a day and about 3 liters of fluids a day. Once you are there, you will be in a very happy place for the most part. Of course, beyond that, if you're having symptoms, then yes, we're gonna go into step by step into their symptomology. But fiber and fluids those guys need to be maximized first.
Well, and I think that that's a good point to bring up with fiber. I think I read years ago, the average American eats 8 to 10 grams of fiber per day. And I know when I will ask people, well, do you eat vegetables every day? And they say, not every day is probably the most common. Or I said, do you eat them with lunch? And they say, well, no, only with dinner. I said, well, then how do you get all your servings in if you only eat them once a day?
Yeah, it's surprising with the amount of supplements and the what's it called, the fish oil and the other stuff which our patients eat. I mean they take, but they forget to take a simple supplement like Benefiber or Metamucil, which is a very organic way of actually ingesting your fiber. If you are not typically a vegetable eater or a plant-based eater, taking 1 tablespoon of Metamucil, for example, gets you about 11 grams of fiber. So if you do 1 in the morning, 1 in the evening, you're already above 20. All you gotta do rest is like 8 or 10, which you are probably getting from the rest of your diet.
So actually, I do have one more question. I'm glad you brought that up. Do you have a, I will usually tend to recommend Benefiber or Metamucil because of the water, since you have to drink water with them over fiber chews. Do you have a particular, since the types of fiber are a little bit different in Benefiber and Metamucil, do you have a favorite, something you recommend as a supplement?
I like Metamucil more because, like I said, 1 tablespoon of that in itself gives you 11. And with that, they are forced to drink water, which I want them to be drinking water. And Metamucil also is now in like different flavors, like orange and this, which has made it more palatable. In the past, they used to be Consul, which is still there, but it's very chalky, in my opinion. I'm sure Consul people are not going to like what I'm saying, but Metamucil has actually made it very, very different. Now it's much easier to kind of ingest. So I typically go to Metamucil as the first line. For some reason, if they say no, it's making me bloated, then I say, okay, you can try Benefiber or Citrusel. I have no problems with that.
Okay.
I don't even have problem with wafers or gummies.
Okay.
Whichever way you want to take, you take it. Just hit the number which you want to be hitting there.
Okay. Oh, good. Thank you. Okay.
All right. Well, we want to thank you, Dr. Vade, for your time this evening. We know that a lot of the things that you presented on were the types of things that Amy and our other dietitians hear and, try to guide our patients on. And so when we talk about resources, we do have these presentations saved on our YouTube channel, which is United Medical LLC. As Amy mentioned earlier, you can go to umusa.net. That is our website for the company. You can click on For Patients, and then under Wellness Programs, you'll see Diabetes and Nutrition Program listed. We have a whole host of resources there. We have the handouts. So Amy talked about some of the diet handouts. We have meal tips. We have shopping tips. We have some recipes. We have a lot of things out there. We also have quick tip videos that Amy has been doing since last year. So they're around 5 minutes, and they're a variety of topics to help our patients. We have how to treat low blood sugar, how to use your glucometer, label reading. This year, she's done a new series where we talk about mindful eating. We also talked about meal prep. So we think a lot of that is important, regardless of what you're eating. If you're prepared, then you're less likely to eat fast food and all those things that Dr. Vade and Amy talked about tonight. If you plan ahead and you buy everything that you need for that week's worth of meals. And Amy also did a cooking demonstration for us. So those 3 were for this year, and we're going to be meeting in June to do some additional quick tip videos. And then we also have this full wellness series out there. So you can see all of them. We do them twice a month, and we started last August. So there's quite a library out there on a variety of topics. So please feel free to watch all of those. And Amy, do you want to talk just for a moment about our upcoming webinars for May?
So our next webinar is May 12th, and we're going to be talking about eating out with diabetes. So if you're going out to eat, which restaurants are reopening, and we know people eat out a lot, some people do. So what are your best choices? If you're going to go, if you have to do fast food, what's the best choice? If you're going to fine dining, if you're going for Mexican food or Chinese food, what's the best thing? And we're going to have a little quiz for Kamal and Donna and see
We
how
better
they do.
study up.
So that should be interesting.
All right. Well, again, thank you, everyone, and we look forward to seeing you in May on the 12th. Good evening, everyone.
Thank you, guys.
Thank
Have a good
you.
evening now. Bye-bye.
Bye.